All right. Well, thank you all again for joining us today. My name is Fide Pineda, and I will be moderating today's webinar along with my colleague, Dr. Jose Leon, and also Aaron Williams from the National Council for Mental Wellbeing. The webinar today will be focusing on synthetic opioids and the impact on community health. This webinar is presented by the National Center for Health and Public Housing and the National Council for Mental Wellbeing. So before we continue, I'd like to go over a few housekeeping items and just a reminder to everyone that you're muted upon entry. Please make sure that you also engage in the chat. If you have any questions, please raise your hand, or also you may click on the button at the bottom and submit a question through Zoom. Your line is also muted right now, so if you have a question that you would like to ask verbally, we can always unmute your line during our Q&A session. This webinar is also being recorded, and the slides and the recording link will be sent via email shortly after today's session. I have also already uploaded a copy of the slides into the chat, so you should have access to those right now. Additionally, we'd like to know more about you, so please let us know in the chat what is your name, your title, the name of the organization, and where you're joining us from. So thank you so much and welcome. So about the National Center for Health and Public Housing, the mission of NCHPH is to strengthen the capacity of federally funded public housing primary care health centers and other health center grantees by providing training and technical assistance. The content of this webinar is 100% financed by the Health Resources and Services Administration and do not necessarily represent the official views of HRSA, HHS, or the U.S. government. So again, my name is Fide Pineda. I am the TTA manager here at NCHPH, and with us, we also have Dr. Jose Leon. He is the Chief Medical Officer at the National Center for Health and Public Housing. And we're also very honored to have with us Aaron Williams. He is the Senior Advisor at the National Council for Mental Wellbeing. He will be our guest speaker for today. So Aaron has over 20 years of experience delivering behavioral health training and technical assistance with expertise in substance use treatment, prevention, recovery, workforce development, and evidence-based practice implementation. He has contributed to numerous publications on substance use, primary care integration, SPURT, behavioral health workforce development, recovery supports, and the use of medications for substance use disorders. In recent years, he has also led major projects supporting medication adoption and recovery-oriented systems of care, including Project Echo-style learning collaboratives with community health centers nationwide. He also develops tools, resources, and subject matter guidance for diverse stakeholders such as federal grantees, rural providers, and program staff. Aaron also holds a bachelor's degree from Morehouse College, a master's degree from the Catholic University of America, and a certificate in strategic management from Georgetown University. So for today's learning objectives, we will be describing the emerging threats of synthetic opioids in the nitazenes class. We'll also be providing or identifying secondary prevention strategies that community health centers can implement in public housing communities, and explore how to develop a plan around engagement of community members in public housing and other at-risk individuals. And I see in the chat that we have some participants letting us know where they're joining us from. So welcome and thank you so much. And without further ado, I will pass it on to Dr. Jose Leon to continue with today's presentation.
Thank you, Fide. And hello, everyone. It's such a great pleasure to be part of this presentation. And this is a really good webinar. The topic is one of the HRSA priorities and one of the emerging issues that we have seen in the last few months here in the United States. I will provide an overview of public housing primary care health centers, and then I will pass it over to Aaron, who will be going over the content of this webinar. In 2024, health centers reporting that they serve over 32 million patients, and there are 485 health centers located near public housing. These health centers serve 6.7 million patients, and 107 of the total of health centers close to public housing are public housing primary care grantees, which means they receive federal money to provide services to these patients. And in the same year, they provided services to over 1 million patients. Next slide, please. The same document or the same report, the Uniform Data System, provides some information about the demographic of those patients being served by public housing primary care health centers. And it's important to note that over 76% of these patients are below the federal poverty level. Almost 60% are female patients, about 27% are children, almost 12% are senior patients over the age of 65, and almost 19% are uninsured, or these patients are not receiving any type of assistance, and health centers are helping these patients and provide these services based on the ability of the patients to pay. Next slide, please. In regards to those living in public housing, and this is data from the U.S. Department of Housing and Urban Development, there are around 1.6 million patients, or 6 million residents living in public housing, and about 2 persons per household. It's important to note as well that 32% of these patients or these households are female-headed, and they have children. This number or this percentage is also very important when you provide services to these patients. There are some issues in regards to access to care. Generally, all these patients are full employees, and they need to take care of their children. So whenever you are having conversation with these patients, it's really important to see and to make sure that we understand the difficulties that these patients have to access care or primary care. Next slide, please. It's also important to note that around 35% of these patients are under the age of 16, that 40% of them are senior patients, and 23% are disabled. So this is also very important because the National Center for Health in Public Housing has been providing some webinars and some training materials for those health centers serving people with disabilities. And again, this is a huge issue for these patients to have access to care. So it's really important to see that these patients have either a mental disability or a physical disability. And it's really important to develop strategies to make sure that these patients are coming to our health centers and are receiving the care that they need. And 90% of these people living in public housing are low-income population. Next slide, please. In regards to substance use disorders, the UDS data, the 2024 UDS data also show that when you compare all health centers We are talking here about the 1,300 plus health centers providing services versus the 107 public housing primary care grantees. They are having exactly about the same percentage of patients who have a substance use related disorder that is not tobacco use. So here we are including opioids and other substances that patients are using, and it's really important to see that even in health centers providing services to public housing residents have a higher percentage of patients with substance use disorder. Next slide, please. In regards to the patients who are receiving screening, brief intervention, and referral to treatment, the percentages are about the same where you compare health centers and public housing primary care grantees, but there is a higher percentage of those of public housing primary care grantees providing SBIRT services to patients. So this is also very important because they are trained to identify patients, screen patients, and refer these patients to the resources and treatments that these patients need in case they have any substance use disorder. Next slide, please. In regards to the use of opioids, this data is from the health center patient survey data. HRSA compiled these numbers, and when you compare those living in public housing versus those HUD-assisted adults or those living in other housing, the numbers are also about the same. They are having exactly the same information and diagnosis in regards to opioid use. So it's important just to see that regardless of the populations being served by health centers, the numbers are about the same. Please keep in mind that there are other populations being served by these health centers. For instance, people homeless populations that are more likely to have substance use disorders as well. Next slide, please. And this slide is also showing the total clinic visits for substance use disorders and is comparing FQACs with PHPCs. And the numbers, even though they look if you look at the FQACs, the numbers are higher. This is because the number of patients served is the population, the total population is larger when you compare it to public housing primary care grantees. But when it comes to percentages, the percentages are about the same as well. Next slide, please. Before I pass it over to Aaron, some of the health centers providing services to patients diagnosed with substance use disorders are certified community behavioral health clinics, but there are others that do not have this designation or are not receiving funding from SAMHSA in this case. So it's always important for those who are not fully familiar providing these services to connect with certified community behavioral health clinics in their community to make sure that if you are not providing these services for your patients, there are other clinics that are providing these services, and you can connect patients specifically when there is a referral. And we are going to go over a case study showing the need to identify these patients and follow up with our patients. Next slide, and without further ado, I will turn it over to Aaron.
Hi, everyone, and thank you, Dr. Leon, for giving us that update. I think this is some very interesting information about, the health centers and how they're beginning or their ongoing effort to try to address substance use, which I think all of us know is still a significant public health problem in this country. So, thank you all for joining. I'm going to spend the next few minutes here talking about an emerging threat, related to substance use. I think we all sort of know and understand substance use as a significant public health problem issue in lots of places across the country. And I'll talk a little bit about, some changes in drug supply, particularly the use of nitazenes as a part of the supply. I'll go over a few things first, kind of where we are as it relates to opioid use disorder in this country, and then kind of move into that conversation. And I'll end it by giving some thoughts about what health centers can do to more comprehensively address some of these emerging threats, particularly the opioid-related and synthetic opioid-related threats. So if we go to the next slide. All right, so just to talk a little bit about where we are in this country, again, significant use of substances, a significant public health toll that substance use has, loss of life, longevity, morbidity and mortality, quality of life, significant burden on the healthcare system, significant burden in terms of family, friends, interpersonal relationships, often lots of criminal justice involvement and use. So we really have, I think a ways to go in terms of addressing this issue in this country. There have been some improvements, but the data right now indicate that there's still a bit of work to do. The data on the slide is related to 2023 data and 2024 data related to the National Survey of Drug Use and Health. That is the survey from the Substance Abuse and Mental Health Services Administration, which is the sort of chief administration around substance use at the federal level, and they every year do a relatively large survey, anywhere between 50 and 70,000 people around substance use. So we have about 48.4 million people who have a substance use disorder. You also have another 73.6 million people who have used an illicit drug in the past year. And I think as everybody knows, over the last decade plus or so, we have been in the midst of sort of or waves of an opioid overdose epidemic. Those numbers have skyrocketed in the last decade plus. They have come down a little bit now post-COVID, but still this number of 80,000 people that have died of a drug overdose, the vast majority opioid-related overdose, the vast majority of those now synthetic opioid overdoses, is still a number that is far too high of a number in terms of lost life. Next slide. So as we kind of dive deeper into this conversation, in 2024, we still have relatively significant use of prescription painkillers. And this chart on your screen, again, from the National Survey of Drug Use and Health, talks about how people are, getting these prescription, pain medications and sort of what's happening there. We have 8 million people age 12 or older who misused prescription pain relievers in the past year, which really sort of contributes to some of these other problems. Many of those still get it from a healthcare provider, either written or stolen prescription. Lots of others, get it from a friend or a relative or sort of raided a medicine cabinet and took it. You still have others who are, doctor shopping and doing all of those kinds of activities, folks who are raiding pharmacies, and then a few others who are still using kind of a dealer on the street or some other stranger. But the proliferation of prescription drug misuse, is still a particular concern in this country and contributes, I think, to a lot of the other substance use and some of the problems, particularly related to drug overdose in this country. Next slide. So as we kind of look a little bit deeper and focus more particularly on opioid misuse, particularly among folks who are 12 and older, you see kind of a mix here where you have almost 225,000 people who are using heroin mostly exclusively. Another 331,000 who are using heroin plus opioids, some other prescription opioid. But the bulk of people are misusing some sort of prescription opioid, with 7.2 million people falling into that category. In terms of exclusively using, heroin, 556,000 people with some sort of heroin use. And again, another 7.6 million total with prescription opioid use, which is the bulk of the people who are make up sort of this chart in the survey. So again, significant use of opioids in particular, which again lends itself to lots of issues, particularly related to overdose, that we'll get into here in a second. Next slide. All right, so let's talk a little bit about kind of where we are today. I've mentioned a little bit of this. We are still kind of in the throes of an opioid overdose epidemic. And with that, there have been a number of changes in terms of the opioid supply. Thinking about what I think most of us understand is the use of synthetic opioid, in particular fentanyl, still being kind of the dominant opioid, particularly when we think of synthetics and when we think of overdose in more recent years. It has certainly contaminated the drug supply. In many places across the country, people don't know that they're taking it. There are a few pockets of the country where they're seeking something like fentanyl out explicitly. But in most cases, it is sort of either adulterated the drug supply in fake prescription medications that are all over the streets and causing significant problems, as I think many of you know, around overdose. So now adding to this mix in more recent years is a set of synthetic opioids called nitazenes. They're beginning to be seen across the country and emerge, and it's causing real concern among many people in the public health space, particularly with their high probability for overdose and other sort of serious incidents. So what are nitazenes? So what we're talking about here is really a class of really powerful novel synthetic opioids. Originally, they were pulled together in the 1950s and developed actually as a way to replace as alternative for morphine. I think if people sort of understand some of the history, there's a long history of use of morphine, particularly in this country. I think folks were looking for some sort of an alternative, to address some of the concerns around morphine, and ended up producing a class of opioids, synthetic opioids that actually were far more powerful in some ways than what we have traditionally seen in fentanyl and other synthetic opioids. Nitazenes were actually never used or approved for medical use, partly because of how potent they were. And so they just have kind of been around, but in recent years, as a part of the drug supply now, we're seeing them reemerge. In terms of where we are with them in the United States, There are some nitazenes that are actually a part of the DEA drug schedule. They are scheduled as Schedule 1 medications. Again, no medical use for these substances. And there have been at least 13 different types of nitazenes that have been identified. The most common that we see is one that is isonitazene or ISO. And there are some others. So you may pop up as you are continuing your work. They're listed here. I won't go through all the names largely because they're sort of long and yeah, I don't want to screw up the pronunciations, but there are a number here of nitazenes that sort of fit into this class, that we want to be aware of. Isonitazene is really the one that is most common, but certainly there are others. Again, these are really potent synthetic opioids, and certainly things to be aware of as we move forward in some of the emerging trends here. Next slide. So when we think about nitazenes, what are we really looking at here? So again, similar to many other drugs that people may have seen on the streets, they typically show up in a white or brown, yellowish kind of powder. You may even see it as sort of crystals. They're often made up as counterfeit pills that resemble prescription opioids like oxycodone, even Dilaudid, and other prescription opioids that people may be looking for on the street. So we have to certainly be careful about that. It can come in liquid, nasal, or vape solutions. Nitazenes can be swallowed, snorted, smoked, vaped, or injected. So multiple modes of delivery of this particular opioid. Next slide. Because we can kind of bring all of these in. So over the last, I'd say 6 to 7 years, we've seen some shifts across the country, several places where this is beginning to pop up and people are beginning to see nitazenes on the streets. Seeing there's some information I talk about later, the state of Tennessee, where they've seen some emergence of this, before COVID and going into kind of the COVID era. Washington, D.C. Itself is also seeing some nitazenes on the street, which is, again, causing lots of concern, both at the local level and the federal level, particularly the DEA. These are just sort of highlights I pulled from articles and headlines, that have been printed over the last 6 or 7 years, beginning to sound the alarm about nitazenes. These are very potent drugs and potentially can cause lots of problems. And we see them, beginning to rise in the supply of substances. So this is of concern to all of us who are trying to address and treat substance use across the country. Next slide. So let's talk a little bit here about some of that progression. So right now, nitazenes have been identified in at least 4,300 law enforcement drug seizures since 2019. So a number of these sort of cases now, when they're doing sort of the checks, they're coming up with nitazene as a part of the drug supply. There are other studies that have found nitazene identified in U.S. wastewater. So clearly there are people out here using these. Now, to be clear, again, they were never approved for any sort of medical use or medical purpose, in the United States. So certainly if we're seeing this in the wastewater, we know that there's some level of, illicit use and or contamination happening as a part of that. Again, that data looked at, I think, states of Washington and Illinois, and which really demonstrated that this is a problem that's beginning to grow across the country. Tennessee, they actually published some data about what has happened, particularly as it relates to overdose. In Tennessee, they went from 0 nitazene overdoses in 2019, then popped on their radar screen 10 overdoses in 2020. and then 42 in 2021. So again, this is a significant increase in what may be happening across the country here. I mean, I don't want to sound the alarm too much in terms of the relativity of the use, but certainly this is an emerging threat, really in particular because of the potency of the substance. All right, so when we think about this, going forward, again, fentanyl is still the most common illicit synthetic opioid, but certainly there are others that we need to make sure that we're aware of. Next slide. So let's talk a little bit here about nitazenes versus fentanyl. So again, when we think about this, nitazenes have an even higher risk of overdose because of their potency. And, keep in mind that, for years we have been very concerned about the potency of fentanyl, and how significant the risk of overdose is with fentanyl. Here we have something that's even more potent. Some of the studies indicate that it's anywhere between 5 and 40 times more potent than fentanyl. And really, when you think about that increased risk, it often means that many of the life-saving medications like naloxone and other sorts of medications, overdose reversal meds, you may have to administer more than one shot in order to revive someone that may have nitazenes on hand. We were already very much concerned about that with fentanyl, but now certainly with nitazenes, we're even more concerned about this. The other piece, which may be even more important than I think others may think, is that most people are unaware that nitazenes are part of the supply, or that they have ingested nitazenes. When you talk to them about it, they may not even know what it is. So often, that creates a secondary problem where we have people who are using and certainly not expecting, this to be available, so they don't take any precautions, in terms of use. So certainly we want to think about how we address these things in a very holistic way, but certainly something to be concerned about. Next slide. All right, so when we see, nitazenes, health consequences, very similar to other opioids. Again, just a bit of a higher risk of these things, certainly overdose risk, really significant. Lots of issues around tolerance and dependence. Withdrawal symptoms can be a bit severe. Cardiovascular effects, some mental health concerns, particularly related to the use of nitazenes, and also increased risk of infectious disease. So again, a lot of issues around morbidity and mortality related to nitazenes. And these are all things that you may encounter in your work in health centers. So how do we begin to mitigate these things? How do we begin to be proactive and make sure that we have the right tools to address this kind of concern? Next slide. All right, so I'll talk a little bit here now about how we might want to think about engaging and addressing nitazene use, and really prepare ourselves to really be as effective as we can possibly can to address it and really get people into long-term help and care. Next slide. So here I want to just talk a little bit here. I don't know if folks have seen this before, but part of my thinking about this is, in order to address these something like nitazenes, certainly you want to have some preparation related to overdose and overdose reversal. That, I think, that goes without saying on some level, but really to address these kinds of things in a more holistic way, you want to make sure that you have access through partnerships such as what Dr. Leon mentioned with certified community behavioral health centers. or other entities, and building your own internal capacity, you want to make sure that you are really offering and have available the whole continuum of care, particularly as it relates to substance use. So here, this sort of rubric and slide is kind of taken from the Surgeon General's report in 2016. At that time, it was the first Surgeon General's report ever on substance use. And Dr. Vivek Murthy, I think, and his team really did a great job of distilling the science around substance use, or where we were at that moment. And one of the things it did was it began to have a broader conversation, both about the language, how we talk about substance use, but also about shifting us away from more incarceration-focused solutions for substance use and more towards a conversation about public health. And as a part of that, they also developed these sort of categories of continuum of care and sort of service delivery. And so at the top of this, we talk about these ideas which many health centers are all engaged in of enhancing health, right? So general health promotion, looking at how do we promote optimum health in individuals and in communities. So you see here lots of work done in communities like health fairs, health screenings, really out in the community doing these things that promote like health and wellness. Also, as a part of the continuum, you also see what we call primary prevention activities. So those are these activities that are really designed specifically to address substance use. Those activities include environmental strategies like alcohol taxes, tobacco taxes, just say no campaigns or campaigns to reduce and cut back the use of illicit substances. So really these primary prevention tactics that really can help reduce the use of substances. We also see early intervention strategies. Many health centers are doing this, screening, brief intervention, and referral to treatment. Those numbers were talked about by Dr. Leon in terms of how much health centers are doing that work, because it is important to really identify earlier in the stream substance use and then try to address it at those points, really meeting people where they are with the right kind of intervention. It also includes here other secondary prevention activities like overdose reversal and the like. So here is where some of that work to reverse overdose or mitigate, some of the harms of substance use in some way are thought about and I think discussed. So moving past that, you think about more formal treatment supports, having medications for addiction and addiction treatment, really thinking about group therapy, individual therapy, all of the kind of conventional treatment activities that most of us kind of think about. But certainly as a part of this is the use of medications. It was great to see that a number of the health centers, a good number of them have prescribers of MAT, some of them even having upwards of 10 or more prescribers as a part of their health center network. That's really good in terms of having comprehensive services for people around substance use. And then we also have recovery support. So recovery support services really provide a number of different services from recovery housing to recovery coaching and the like that are really designed to help people move from the treatment phase and into recovery and long-term recovery from substance use. So you really, want to be looking at how you can use peers and recovery support to enhance some of those services. And the reason I bring all of this up is because in order to address some of these emerging threats like nitazenes, you're going to need to have a very comprehensive approach to doing that. So you really want to know kind of what that space on the continuum looks like, what services are, how you sort of move through that to better address these types of emerging threats. Next slide. All right, so when we think about addressing this, you really, I think there are lots of kind of comprehensive strategies to engage in, in terms of, addressing overdose. I think many of you all have some standard overdose protocols. So I encourage you not just to have those, but to do training and updates, excuse me, to those protocols, recognizing that particularly if you're in a space where you think that nitazenes may be a part of the supply, you're beginning to hear much more about that, having a protocol to make sure that you have enough opioid, reversal medication, making sure people are trained, and thinking that they may have to use more than one dose in order to address a overdose, and all of those other, sort of emergency strategies. But I also think that health centers may need to be going beyond that, right? So looking at, again, that broader continuum and what else can you be doing? Much more general staff education around substance use is always helpful, in addition to just that emergency preparedness kind of education, but having those in-services with staff about all of these different threats and what you may want them to do in terms of a response. Also, public awareness campaigns in the community, right? So, how are you preparing the community about what to look for, what signs and symptoms, when to bring somebody to the health center, when can they go to the hospital? So really getting people out and about in the community, talking to them about these threats and what they need to be doing to address them. Also integrating MAT and other treatment services. So if people are having issues, particularly opioid use disorder, and using services to try to address that, it's important that you have that holistic approach, which includes medications. Opioid use disorder, to really demonstrate and move forward in terms of addressing it, very often medications will need to be included at some point. So thinking about how you can deploy those medications and make sure that people get the right service at the right time. The other thing is partnering with other institutions within the community. I often say in some of these presentations that substance use is a community problem. If someone is knocking on your door with a substance use challenge, there are others knocking on the door of other public health institutions with similar challenges. So really, thinking about how you can partner with public health to really look at better addressing this in a more comprehensive way. Public health services do lots of health and wellness campaigns, lots of getting information out to the public about some of these kinds of threats and what to do. Certainly you can do lots of community and family education as a part of that. So I think there really are some ways to engage in that kind of partnering and doing that work within the community. Also, just as a part of that is thinking about your local treatment providers. If you are someone that is, near or in the area of a certified community behavioral health center, I'm certainly looking at, having conversations with them as they have, lots of sort of resources related to behavioral health, or at least enhanced resources related to behavioral health that will allow you to, augment your own resources potentially, to address some of these issues and threats. Next slide. So I think in general here, I would say that really you want to make sure that you cover your bases both from an emergency perspective and have the kinds of resources and training you need to address emergencies, particularly with something like nitazene. But you also want to look more broadly and more comprehensively to make sure that you are doing all the other things that both make the community aware and can prevent some of this use from occurring in the first place. That is the way I think you really reduce the harm from some of these new and emerging threats. There will always be a new sort of drug that we're looking at and sort of checking on in terms of how people are using it across the country. But what is necessary to address all of that is a much more comprehensive look at services and working with the community. And I think health centers are at the heart of that conversation to really address these things. So, and that's kind of my broader conclusion about this. And I think we can go to the next slide. Here are just some resources so you can do a bit of a deeper dive around nitazenes. There's some bulletins that are out and other things. Again, this is a emerging threat that a lot of the major agencies are beginning to track, CDC and other places. So I encourage you to take a look at those. Also, if you need other technical assistance, the Opioid Response Network has, no cost technical assistance, to the states and community providers within states. They have a wealth of resources, a number of different partners who work with them. So I encourage you to check them out as well. All right, so I guess we can take some questions, I guess now, and then maybe we'll talk a little bit about a case study that gives some more examples of how we might want to think about addressing something like this.
Thanks, Aaron. Thanks for your great presentation. You covered many important things that health centers need to know, specifically what a nitazene is or nitazenes are, some data about the incidence, and the emerging, that this is an emerging issue that we need to be aware of. Then you provided some really good recommendations about how health centers can work in the community and what they can do to address this important issue. And next slide, please. So if you have any question for Aaron, please, this is the time to ask any questions. You can either type your question in the chat box, or you can verbally ask your question. You can use the hand raise icon, and your line can be unmuted. Well, we wait for some questions, Aaron. There's something that came to my mind when you were talking about naloxone, and that sometimes because of the potency of these drugs, you can need more than one of dose of the medication, to revert the effects of medicine. In the community, there are some patients and some family members with this drug. Is there any education or recommendation for these members who have access to the antidote, and educate them on how to use it when at one dose is not enough?
Yeah, so there are a couple things to think about, right? So one is how we distribute these overdose reversal medications. You want to make them as accessible as possible within communities. There's I think a few studies now that have talked about this, like overdose reversal saturation and overdose. So the more saturated communities are with these medications, often they tend to have overdose rates that either are lower or go down over time, given that saturation. So one of the things I would say thinking about this is either health centers or public health entities is make sure that they're incorporating these conversations about these synthetic opioids into their trainings related to use of the reversal medications, right? Often people don't know that they're taking these things. So you need to take sort of a better, safe than sorry approach in that, telling family, friends, others who might be around to administer these medications, like, hey, if you aren't seeing signs of recovery from this, you may need to use multiple injections and really have them thinking about that as a part of their work. There's some other things around that are happening. There's all of the sort of legal aspects that there are a lot of states now that are doing, Good Samaritan laws and other things to try to help mitigate any issues or concerns people have about wanting to help or staying on the scene to make sure someone gets the help they need or revived. So you want to make sure that you are conveying that message to people that, hey, synthetic opioids are out here. Many of them you may need multiple injections to recover. So if you aren't seeing those signs, in relatively short order, give another dose or another injection.
Thank you, Aaron. And this is a great message. When we started this activity, this webinar, I saw that we had some community health workers, and they are the ones providing that education to our patients and to the community. So that is a great, that's great information for them, how to educate these patients and making sure that they understand that a patient will need more than one dose of the antidote. Thank you so much. And next slide, please.
Before we continue, we do have a question.
Oh, we do? Okay.
Yes. The question is, as a public health network in an area that deals with lots of stigma, what initiatives have worked in your area that address with prevention?
Well, I think there are a couple things, right? So stigma, there's sort of several layers to stigma. Certainly there's lots of stigma around drug use in general. There's also stigma associated with use of medications, particularly opioid use medications in general. So I think there's a lot of public education, a lot of provider education that goes into creating a space where people are comfortable, one, with addressing some of the overdose concerns, but two, getting people into long-term care services that, often involve, the medications. So I think there are lots of things that have worked across the country. One is, engaging the recovery community. Often, a lot of, the stigma, you engaging the recovery community and really addressing maybe even concerns that they may have may go a long way to getting them as advocates to address some of these issues around use of these medications, overdose reversal medications, other medications, and the like. So talking with them, dialoguing with them about those kinds of things. Lots of public awareness campaigns, but also really that having that community dialogue, I think is a critical conversation to have. The other thing, just really quickly, I would say is, having conversations with your first responders to really addressing many issues and concerns that they may have. Often they are at the front line of this, and they often see people who have overdosed multiple times. And so talking to them both about, some of the issues around trauma that they may be having, but also about their own kind of, concerns related to the medications and sort of this entire prevention kind of policy and strategy, right? I mean, people can't recover if they're not alive, and that's a big part of what we're trying to do is keep people alive and get them to the appropriate resources. So, lots of conversation with these key sort of folks, I think, go a long way to help with this.
Excellent. Thank you so much, Aaron. Do we have any other questions, Fide?
That was it.
Okay, thank you. Quickly, we have about 4 minutes to go over a case study. We would love to hear from any of the health centers or organizations participating in this activity. Every time that we have conversation with health centers, they are looking for promising practices or something that is working in the community. And this is the reason why here at NCHPH, we would love to have some case studies just to make sure that we can get additional information on what you're doing. If in the next few minutes, if someone can chime in on this, please let us know. But the case study is about man with a known history of smoking isonitazine, and he was found deceased in his home. He had voluntarily admitted himself for isotoniazine detoxification 2 months prior. During the hospitalization, he described how he had developed an addiction to the relaxant and euphoric effects of isotonizines. That quickly led to a physical dependence requiring greater doses to avoid withdrawal. He explained that his previous withdrawal symptoms often included sweating, nausea, jaw tension, and intense psychic stress. While detoxing in the hospital, he exhibited psychomotor agitation, insomnia, and episodes of cold sweats consistent with opioid withdrawal. The patient was discharged after only 7 days at his request, following the cessation of withdrawal symptoms. Providers in the hospital conducted a psychoeducational interview and determined that his judgment was intact with the absence of cravings. Therefore, he was allowed to leave. Upon discovering his body 2 months later, investigators found a vaporization pipe and a white powdery substance later confirmed to be isotonizine. Next slide, please. It's really important to mention 3 or 4 talking points after this case study. First is really important to know that even though the prognosis for a patient with chronic use of these substances, they are not referred to follow up when they are hospitalized. So this is really important for health centers to understand that if this is a health center patient, the communication with the hospital or the system treating this patient is necessary. Second, is also important that when you have a patient and this patient has an acute episode, this is the right opportunity to talk about intervention with patients. Really important for those helping patients, and specifically when they have acute episodes. Then the third one, which is extremely important as well, is that every time a patient is released, the patient needs to be advised to contact either the clinic, the primary clinic, or the health center. And only a few patients are receiving this advice. And the last one is one out of 3 patients is discharged without follow-up, and there seems to be an unused potential for primary care involvement. So these are 4 talking points that are going to be very important for health centers to consider. Next slide, please. And in the last minute, if someone can just chime in on any of these questions, what additional steps who have been taken for this patient after he was discharged, and what resources are available at your health center to assist this type of patients? And if you don't have any, how do you work in the community to monitor the progress of patients with acute substance use disorders? Anyone who would like to chime in, the line can be unmuted. If you have any promising practice that you would love to, that you would like to share with us and the other organizations participating in this activity, please let us know.
In our health center, we pair with a peer recovery support specialist when someone is admitted with a substance poisoning, and they connect with the patient and let them know that they are there to help connect them with resources and recovery if so desired.
Excellent. Thank you so much, Julie, for that. It is really important to have these type of programs and protocols, as Aaron mentioned. And this is the right time, to review all these protocols because of the emergence of these new substances that are affecting our communities. And thank you so much. Anybody else? Otherwise, we can move to the next slide.
I was just going to add that I do think that there's increased the potential for PCP involvement increases a good idea, because I think we're missing an opportunity there with that. Even though the peer recovery support specialists do follow through for a while, I think it's important to include PCP in their care as well.
Mm-hmm.
That's a great piece of information, Julie. Yeah, we fully agree with you.
Yep.
And thank you so much for letting us know what you're doing in the community and the piece of advice that you provided. Thank you. Next slide, please. So we are about over time. We had the Q&A session, unless somebody else have another question. Otherwise, these are going to be our upcoming events. You can go to our website, the nchph.org website, where you will find additional information on the type of webinars and activities that we're doing to train health centers. Next slide, please. You also can visit our website and find new resources that we have available, and not only related to substance use disorder, but other topics that are important for health centers. Next slide, please. Please don't forget to complete our post evaluation after this webinar. Your information is very useful, and with your comments as well. If you're doing something different, if you are providing other services to your patients as well, this is the right opportunity to let us know. Next slide, please. And if you have any questions, you can contact us. This is the slide showing our contact information for all the staff members. And thank you so much for attending this webinar. Aaron, thank you so much for this great presentation, and looking forward to working with you in the future.
Yeah, great. Thank you all. I appreciate the opportunity. Thank you.
Thank you.
Thank you, Aaron.
Thanks, everyone.
Thank you, everybody.
All right.
Thank you.